Good afternoon and a warm welcome to you to this webinar. We are MedGenome, the leaders in genetic testing in India, and the topic for today's webinar is the genetics of autism spectrum disorder. And our speaker today is Dr. Sheetal Sharda, Senior Consultant and Clinical Geneticist at MedGenome. Dr. Sheetal is a pediatrician and has done her DM in medical genetics from SGPGI Lucknow. She has worked as an associate professor in genetics from PGIMR Chandigarh for 8 years. She has over 14 years of experience in clinical genetics. She also has about 30 publications in national and international journals to her credit. Her areas of interest are dysmorphology, prenatal diagnosis, and molecular diagnosis. And so before I hand over to Dr. Sheetal, I wanted to inform the audience that if you have any questions or comments, you can type them into our Q&A or chat window of the Zoom conferencing browser that you're seeing this webinar through. And we will also be sending a recording of this webinar in case you missed out any points or would like to revisit some points. And so you can expect this sometime in a week or two in your inbox. So without any further delay, I will now transfer the host to Dr. Sheetal, who will take this webinar forward. Over to you, Dr. Sheetal.
Thank you, Joseph. Welcome participants to this webinar series from MedGenome. The topic for today's webinar is genetics of autism spectrum disorder. I was not surprised to see a very large registration for this because ASD has sort of become a very important topic for working pediatricians as well as general practitioners. On the only reason being because of high index of suspicion and the importance of early intervention for this if diagnosed at the right time. So I would just like to introduce this topic. We have recently participated in the Autism Awareness Month, sort of, in April 2019. And the whole month is dedicated to creating awareness for this mysterious disorder, or what we can just say a behavior or communication. I won't say abnormality, but a difference in communication skills among certain class of children. So the diagnosis is basically made on the basis of certain criteria, and these are based on, again, questionnaires given to parents and certain information which the behavior developmental pediatrician or an expert can decipher from just looking or observing the kids in front of them. So the main problem or the main diagnostic things which can be seen in these children would be communication impairment, social and behavioral challenges, and certain repetitive behaviors or restricted interest. And this is basically a comparative of age-related abnormalities seen among normal and abnormal kids. So the main purpose of these criteria is to understand any atypical cognitive profiles in the children. And the earlier we diagnose them, the earlier the behavior therapy can be started with good results. As you all know, it is a complex group of heterogeneous neurodevelopmental disorders, but it is characterized basically by social communication difficulties. And these are unrestricted, repetitive behavior and interest in certain things which may not be a common norm in other kids of the same age group. So being a huge umbrella group of disorders from very mild to very severe form of autistic abnormalities. Unfortunately, the prevalence of ASD is rising. As I told before, it could be because of increased awareness. But as you can see that since 1940s, when the incidence was or prevalence was as low as 0.05%, almost worldwide population now is predicted to be about 1%. And along with just autistic features, it has been found that comorbidities like seizures or ADHD or hyperactivity is very high in children with ASD. And it affects males more than females. For every 4 to 5 boys, there would be one affected girl. And this was an old information, 2012, based on the latest 2018 data of CDC. The estimated autism prevalence could be as high as 1 in 59. So the question comes, is it genetic? This is very important because parents are really concerned about this disorder, and it is a household name. And as soon as a parent hears that the child is even being considered to be a part of the autism spectrum disorder, they are very anxious and start reading literature, and they want to know whether it is an inherited disorder and whether there is a risk in the next child or not. So unfortunately, there is no single gene disorder which can be comprised of, which can be implicated for autism. And it is a genetically influenced disorder, but it can be caused by factors which are non-genetic also. So a child with a genetic predisposition can have other form of factors like environmental factors or certain genetic factors which could contribute to the severity of the disease. But based on the latest literature, it is seen that almost 60% of these kids may have no genetic etiology, but a number as high as 15 to 40% of individuals, if they are tested as per the algorithm, then in almost 15 to 40%, we can know a genetic etiology. So if we consider certain risk factors, then along with the genes, there are environmental factors also. Along with that, there could be certain gene environmental interactions also, which could be causative for autism. And there has been remarkable advances in the literature regarding this because of the genetic tests which are available, easily available to people, and certain alleles or certain disorders have been found to have a high incidence of autism. And based on that, many genes have been specifically identified for contributing to ASD. On the other hand, there have been multiple studies which show the importance of environmental factors which contribute to autism also. So both of them are equally important, I should say. But still, based on latest literature, many questions remain still unanswered. So we don't have a single answer when we say that what is the cause for autism. Now, seeing the role of heritability, how did we start focusing on genetics, that it was a genetic cause? It was because there were identical twins who shared almost 60 to 90% of the autistic traits compared to the fraternal twins. Similarly, sibling recurrence was seen to be as high as 19%, and also because ASD was often associated with certain single gene disorders. So based on this, it was found that probably genetic has a role in autism. On the other hand, there are multiple reports again which make the role of environment as important as genetics, like gestational exposure to high environmental pollutants, or the mother having viral infection, maternal stress. In fact, certain vaccines also are being said to have contributed to the increased incidence of autism. Artificial insemination or ovulation-inducing drugs, these have been studied to have a role in the high prevalence of autism in today's world. The other role is epigenetics, which is a change in the gene, but without having any change in the DNA sequence. So this is after the genetic code is already formed. When a RNA is formed, there are certain histone methylation or methylation processes taking place. And even these have been studied a lot and have been implicated in autism. And this unfortunately cannot be tested very routinely. So coming on to genetic diagnosis, a genetic diagnosis, as I've told earlier, can be identified in up to 40% of individuals with autism spectrum disorders. It is just that we have to understand whether it is just an isolated ASD or it is ASD plus. ASD plus means associated with additional features. Based on this, your differential diagnosis changes, your list of genes which have to be tested changes, the test which has to be done it also changes. So certain additional features which need to be seen or evaluated in children who have been put under the ASD spectrum are whether they are having any dysmorphic features, are there any congenital anomalies of any system which have been missed out on general examination. They could be having microcephaly, they may be having overgrowth, tall, short stature for the family or for the age, and neurological features may be many. along with seizures, weakness, ataxia, cognitive regression. So presence of such features does not rule out a child to not have an ASD. Along with that, there are certain skin or eye changes which also needs to be evaluated. So once you differentiate whether the child is an isolated autism child or he is a syndromic autism spectrum disorder child, the test would differ. So the basic genetic tests which we can implicate or which we can suggest for children with autism, according to the criteria or according to the recommendation, the first line of treatment is chromosomal microarray, and the pickup rate for that would be as high as 10%. For syndrome specific, like after doing the general examination, systemic workup, or examination of the child along with the family history, if you can put the child under some syndrome diagnosis, then the pickup would be much better. Fragile X in male and female both have been told to be the first line of treatment in quite some studies. And in females, if you check according to the typical features which they have of repetitive hand movements, hand breathing movements, bruxism, then Rett syndrome, if we just do the MECP2 gene, almost 4% of the females can be found to have a mutation or a deletion in the MECP2 gene. And then again, karyotype or other testing can implicate, and others means metabolic syndromes also have been associated with autism. So if we see just a face and we try to find any syndrome, if you see this child, he has a very prominent forehead, a long elongated face, prognathism, open mouth, little larger ears. So based on certain dysmorphic features, you can decide what test can be done first. For example, in this child, if you see the photograph, you can understand that he might be a Fragile X child. So in this, the first test you order would be a Fragile X gene testing. But unfortunately, it is not being done routinely in routine labs. So you have to find out which labs do it. And the Fragile X gene testing is not done by chromosomal testing anymore. They are PCR-based tests which test for repeat analysis. This is important because now when we are sending tests for NGS, that is the next generation sequencing, or MLP or chromosomal microarray, Fragile X is not included in those tests. This is a separate type of test, and hence if in a male child you are suspecting Fragile X, it is a separate test and you have to send for repeat analysis by PCR. Now, recommendations for genetic testing in children with ASD is that every child with ASD, you have to have a detailed physical examination to rule out syndromes. And the first test which you would send would be a chromosomal microarray. And then based on whether you are suspecting any typical syndrome, a male child can be tested for a Fragile X, while a female can be sent for MECP2. And thus the major diagnosis can be made just based on a chromosomal microarray and one of these tests. And even after this, if you not get anything, then we have to go further for the next generation sequencing or microdeletion, microduplication test. So single genes and chromosomal syndromes, like there are certain syndromes based which can account for almost 5 to 10% of cases of ASD. It is like these have other dysmorphic features, other phenotypes so typical that they may not be very easily diagnosed as ASD alone. They may be worked off by a neurologist for other syndrome like seizures or severe mental retardation or some other abnormalities. And these are syndromes in which ASD is associated. So based on the clinical features, these can be tested first. For example, Fragile X or tuberous sclerosis, which will have other features as well. Angelman, Smith-Magenis are microdeletion syndromes, and they will be tested by MLPA. So just I will take you along for 2 or 3 cases in which how different tests are required. So this is a 6-year-old child, full-term normal delivery, was asymptomatic till 2 years of age, and then was found to have regression of speech, anxiety, tonic-clonic seizures, poor eye contact, and poor social interaction. And examination showed that the child had microcephaly and very typical stereotypic movements of twisting of finger, nail biting, and The child was put under behavior therapy, and at present, when the child was brought to us at 6 years, the father said that the child has appropriate eye contact, and he was like, she doesn't have ASD because she has proper eye contact. Now, if you see that this is a typical feature of a child with Rett syndrome being asymptomatic and then developing microcephaly. So this is an acquired microcephaly post a normal asymptomatic birth. And in this child, based on this diagnosis, MACP2 gene testing was sent directly, and a pathogenic variant was found, and the diagnosis was confirmed to be Rett syndrome. So what I mean to say that not isolated ASD, but syndromic ASD and with typical features. If you have a female with such features, you can directly send for MACP2 gene analysis, and it has a very good pickup rate. This is another child, again a 2-year-old, and had seizures since 4 months of age, undergone squint surgery, and was referred to a neurologist for global developmental delay, hypotonia, and certain stereotypic movements. On examination, there was very good eye contact and good interaction. But child did have microcephaly, facial dysmorphism, and while walking, the child had features of unsteady gait, which was or could be ataxia. Now at 1.5 years of age, the child was diagnosed to be having Rett syndrome. MACP2 common mutation was tested, and it was negative. The only negative point or a clue which could make this child lean away from Rett syndrome was the child was a happy baby with good eye contact, unlike a child with typical Rett syndrome. So based on this, the clinical diagnosis of Angelman was kept. And when you see Angelman, there are many etiologies for that. It could be a uniparental disomy, it could be a deletion, it could be methylation defect. So a simple test, methylation specific MLPA, is the test which we can go forward for initial, because it will diagnose microdeletion as well as any aberrant methylation. Both of them are tested by an MS MLPA. If you send just an MLPA for microdeletion, microduplication, you might miss out on the methylation testing. But with a MS MLPA testing, both are tested, and this confirmed the diagnosis that this child was Angelman syndrome due to deletion of the Angelman syndrome area on the 15q11 region. Now, the recommended workflow after this, if you want to just summarize, is ASD diagnosis confirmed once you send the child with typical, or you can say atypical features, and a developmental pediatrician can confirm it that it is definitely a child who is falling into the ASD spectrum. You have considered it whether it is isolated or ASD plus. And first tier genetic testing is chromosomal microarray. And then this chromosomal microarray could be negative, it could be positive, it could have a variant of uncertain significance, and moreover, you may also find an incidental finding which cannot explain the features. So after this, it is good to refer it to a genetic department who can evaluate the child further, because once the report is negative or once you get a variant of uncertain significance, you need to reassess the child at regular intervals to see whether there is a change in phenotype. So what exactly is this chromosomal microarray? Just for beginners who are not very much aware of this, I just put 2 or 3 slides for this. It is basically a genomic technology to assess for small duplications or deletions on the chromosomes. When you do a karyotype, it is a visual impression which you get under a microscope. You can see aneuploidies, you can see large translocations, you can see large areas which may be missing. But when it is at a micro level, micro deletion or micro duplications are missed out on a karyotype, and hence the next step. So between a karyotype and between a molecular testing is the chromosomal microarray. So it is possibly known as a molecular karyotype. So you can test for micro deletion and micro duplications in this. So these basically test for small gains and losses, or what is known as copy number variation. And there are various types of chromosomal microarray based on the resolution which you want to see. And it is seen that for autism spectrum disorder, the yield for this is almost as high as 7 to 14%, and the numbers increasing because of awareness. Many people are doing it, and many areas on the chromosome with microdeletion, microduplication, which are having a recurrent in many patients has been picked up. So when you do a chromosomal microarray, either it could be negative, means there is no significant CNVs detected. It will again depend on the resolution, because when the resolution is poor, all CNVs cannot be tested. A single gene mutation cannot be tested by CNVs, and balanced chromosomal differences cannot be measured by chromosomal microarray. So you may have to go for better resolution testing. So if there is no CNVs detected, we have to move further. If it is positive, it means either it is diagnostic because a pathogenic or likely pathogenic CNV has been detected. And then based on this, you can go for screening, you can go for surveillance, you can explain the risk of recurrence, you can do family testing, you can involve the patient or the family in a clinical trial, you can have them enrolled in a support organization. So the finding of pathogenic, likely pathogenic is what we all aim for. But unfortunately, sometimes we might get a variant of uncertain significance. It is uncertain because we don't have enough literature to either classify it as benign and rule it out as being responsible for the autism, and we don't have enough evidence to prove it as pathogenic also. So in such a case, when you get a variant of uncertain significance, either in the chromosomal microarray or in the NGS, you have to offer the test to the parents, and you have to test it along with the parental sample. So this will just help to know whether the variant which we have found is de novo. De novo means the parent should not be having the CNV. If either of the parent has it, then we have to find out whether decreased penetrance has been reported for that CNV. Decreased penetrance means that in spite of having that CNV or in spite of having that variant, the manifestation of disease will not occur. So there are many autosomal dominant genes, many autosomal dominant conditions in which in spite of having the variant, the phenotype is not manifested in one person, but it may be manifested in the other person. So it is very important that variant of uncertain significance has not to be regarded as a negative test until and unless you do it in the parents or another affected person in the family. So finding if it is de novo, then possibly it could be likely pathogenic. Sometimes you may not get literature for that, but sometimes if it is definitely a de novo, that we might get literature and a VUS can be converted to a likely pathogenic variant. Sometimes we get incidental findings which may not be related to the primary, like you have sent for autism spectrum, but we get a variant or a CNV which will not explain the ASD, but it may have some other implication. And for that, it is always better to have a genetic counseling, pre-test, post-test, both, before giving out the report to the patient. So these are certain chromosomal areas in which deletion and duplications have been found to be recurrent. Like they have been found in multiple cases all over the world, and they are not private variants. So almost 1% of the idiopathic ASD cases might have variation in the 16p11.2. It could be a deletion, it could be a duplication. Another is the 7q11.23, which is a Williams syndrome region. Now, Williams syndrome is caused because of microdeletion of this region, but it has been found, and when a duplication is found in this region, it might have a different phenotype like ASD. It is similar to Prader-Willi and Angelman syndrome, the 15q hotspot or a microdeletion. If it is present in certain people, it will cause ASD. If it is a maternal microdeletion, if it is a paternal, it will cause Prader-Willi. But duplications in this same area is also been associated with mental retardation, intellectual disability, and ASD. Right. So after a chromosomal microarray, you might get certain regions, and as you can see, new hotspots are emerging. The importance again of these hotspots or these recurrent copy number variants is that there are certain genes in this region which can be implied specifically for ASD after having been found in chromosomal microarray, implying that these are the genes which may be responsible for ASD based on the fact that they are responsible for cerebellum development, or there are certain brain cell migration genes, differentiation genes, stress response, social skills. So these genes have been implicated after having been found in these microdeletion, microduplication regions. And again, then based on that, these genes which are being shown on the screen are then evaluated by NGS, whether there is a like autosomal recessive form, autosomal dominant form, whether they are deleted, whether they are duplicated, and hence there is a causal relationship between these genes and ASDs. Now, sometimes we may not get anything. So this child, 3.5 years, presented with mild autism. So again, just like other syndromes, when there is a much more severe syndrome, much more severe phenotype, the chances of finding something is definitely more. Like mental retardation, the pickup rate for moderate to severe mental retardation genes is much higher compared to mild mental retardation. Similarly, when there is a case of mild autism, the chances of getting a good finding is often less, because in literature still we don't have much about these genes. Now this child was worked up for chromosomal microarray, and a duplication was seen in 22q11.21, which is a DiGeorge region. But unfortunately, we had found a duplication, which is also found in normal healthy individuals. Hence, this duplication which was found had to be ignored. Now, when this child was tested for NGS Autism gene panel, a mutation, or what we say is a variant, was found in the SHANK2 gene. And when we search literature, it is said that this gene is classified as significant because it has been reported to be implied for autism also. So since it was not reported and it is considered a very rare variant, it could have been implicated. But again, this gene has to be tested in the parents to see if either one of them is having it, so that it can be taken as really significant or it can be ignored. So sometimes we may have to do a stepwise approach. For a patient with autism, we have to do chromosomal microarray. If it is negative or inconclusive, we may have to do a autism gene panel, though we don't have a gene panel right now, but we are on the way of making a very good autism gene panel in near future, along with the chromosomal microarray study. So phenotype is more important. As you can see, it is just a susceptibility gene till date, and we don't have enough evidence. So based on this, it could still be a significant variant, but will be classified as variant of uncertain significant till we get more data on this. Now, this child was referred for epilepsy, delayed speech, and poor communicative skills. He had febrile seizures and multiple episodes. So based on this, he was referred for epilepsy gene panel. On examination, it was seen that the child was toe walking, had typical hand flapping movement, lack of eye contact, and poor communication. So impression was finally kept that he is falling into the autism spectrum plus disorder, because he also had epilepsy along with this. So chromosomal microarray, as per the guidelines, was done first. It was normal. We didn't get any CNV in this. Then we also did the clinical EXOME, in which a hemizygous variant was found in a gene causing a mental retardation syndrome, and it was classified as uncertain significant. And we said, let us do the parents. A mother was found to be the carrier of the same variant, and being an X-linked recessive, it could be like the mother could be a carrier. Father did not have the same variant. So we were still in the dilemma whether it was a significant or not significant variant. But if you see the phenotype, OMIM phenotype, or if you search literature for this variant or this disease, it says that along with intellectual disability, it has features like facial asymmetry, marfanoid habitus, lower lip thickened, nasal speech, cleft palate. So there were multiple other things which was seen in other patients who had this Snyder-Robinson mental retardation syndrome. The child was evaluated again for all this, and he didn't have any of these other characteristic features. So based on this lack of phenotype match, this variant was disregarded. We explained to the parents that based on this, we won't be able to give a diagnosis, and even based on this, we cannot do any prenatal testing because this is definitely not involved with what the child has. So after this, we can see that in spite of doing all studies, all testing, we may not get a diagnosis. But yes, if we have a genetic diagnosis, it can help us guide the management of the child, because if we get certain syndromic type of autism like Cowden syndrome, we know that they are at a high risk for tumors, and so they will be kept under surveillance for those tumors or malignancies. It will benefit the patient and families because we can provide them information regarding what their child has. We can provide them with the psychosocial support. We can help them involved in a support group, guidance and help to prepare for the future, aid in decision making. Sometimes even a diagnosis, if it cannot be made, then a genetic counseling session can at least help them support with that too. So we were asked about the risk of recurrence. So risk of recurrence would again depend on the genetic etiology. If the genetic etiology is not known, then the empiric risk for the next child is almost as high as 10 to 19% as per the literature. And if more than 2 children are affected, then obviously the risk of recurrence would increase a little more. But if after doing a chromosomal microarray or a NGS, if we find that it is an autosomal recessive disorder, then the risk in the next child is 25%. And for an autosomal dominant condition, it would be as high as 50%. And X-linked dominant or X-linked recessive will depend whether it is a male or a female child. And for de novo, in which after doing this testing, we have found it is a de novo, then fortunately the risk of recurrence is as less as 1%. We will not say nil because of various reasons. So if we test and we know that the genetic diagnosis can be made in almost 40% of such children, then definitely we can manage their treatment, manage the complication. We can allow for familial testing. And if it is an autosomal dominant type of thing, then extended screening can also be offered to the family. And the ultimate purpose of doing a deep genetic testing in many of the families is to prevent the risk in the next child. And so prenatal diagnosis can be offered for such families. And sometimes even if it is not for a prenatal or for anything, it allows the families to better understand the nature, history and prognosis. So a child who has been stamped with Rett syndrome, if a diagnosis changes by doing a testing that it is not Rett syndrome but Angelman, then you can give them a better picture of the final diagnosis and how they have to get the child followed up, how the therapies which they do is going to change or not change the management. So yes, the genetic diagnosis is definitely a good way of changing the prognosis of the child. And it also helps to assess specialized support. Now, even for microdeletion, microduplication syndrome, Fragile X syndrome, Rett syndrome, there are many support groups and parents who are affording or parents who are able to use the net, or they can always be promoted to go on net and search for such groups who will help them understand the child better. And also, like, they are more aware of what's happening in their small group of syndromic kids and how they can be helped for that. So just to summarize, it is like, in spite of so much of literature, till date, we are not able to have a very clear-cut genetic diagnosis for kids with autism. We know very little about the risk, but there have been major advances and these are increasing day by day. So the more the number of testing are being done, the more the implications of the genes involved with the pathology of autism are being picked up, and new questions are being raised, new diagnoses are being made. And we also know that based on this, we can have more researches on the gene environmental factors correlation or gene-gene interaction, and like the contribution of environmental factors, how additive or multiplicative effect they have on these kids need to be further explored. A genetic talk cannot end without the ethics. It is very important to know that autism is very complex disorder. The variability is very high, And if we start, if the parents are supported by giving a reproductive choice, they have to be explained that in spite of having the same genotype, the severity of the disease might vary in the same family. And there are many links which are still not fulfilled, and based on just VUS or based on uncertain significant information which we are getting in day-to-day screening and testing has to be avoided, so that certain decisions can be avoided in these. So finally, I'm just putting forward few societies which help for research in this, and you can get much information on what is going on, what researches are going on. If parents want to have more information regarding their kids' diagnosis, then these are certain resources which they can move to. I think this is the last slide. Thank you very much for this, and now we can have some questions.
Yeah. So thank you very much, Dr. Sheetal, for that insightful talk on autism. I now invite the audience to type out their questions in the Q&A and chat window that is there in the browser. And in the meantime, we've already received a couple of initial questions, most of which Dr. Sheetal has already addressed in our webinar. But maybe you can just read it out so that you can summarize some of the answers. And in the meantime, if you can type out your answers, we'll address them live right here with Dr. Sheetal. So start off with the first questions from Dr. Basudev from Bhubaneswar. He wants to know how to approach clinical and isolated autism with other genetic syndromes presenting as autism. What are the different common syndromes encountered by MedGenome and other genetic labs and those presenting as autism?
I think this question has already been taken, like isolated autism versus a syndromic autism or ASD plus. So ASD plus or genetic syndromes, the common ones, Angelman syndrome, Rett syndrome, even tuberous sclerosis. And now there are increased reports in which even DMD kids can present first with mild mental retardation or autism. We recently have diagnosed a child of 5 years who didn't have any much clinical features of DMD, but he was referred for autism spectrum, and we have found a deletion in a DMD gene. And retrospectively, when he was tested, he was found to have raised CPK levels. So DMD also is one diagnosis. The neurologists usually have started doing this, that in every child with mild to moderate mental retardation or features of autism, they have started doing CPK levels, at least to screen out DMD as part of that. And other syndromes, as I have told, Fragile X is common. More so now, we have started getting microdeletion, microduplication syndrome, just as 16p is common. 15q is also coming up, like not deletions, even duplications in these genes have been shown to be associated with syndromic autism disorders.
So Dr. Purvi from Ahmedabad would like to know how to evaluate a case with previous child with autism.
Yeah, we have already done that. If the child is with you, definitely first we have to test the child. If there is no pregnancy at present, then we should explain to them that this is a stepwise approach, because genetic tests are easily available. They are still considered to be costly tests. So if we go stepwise at a time, it will benefit the family more rather than sending all samples together. So based on the clinical features, the severity and the phenotype, we can first send for a chromosomal microarray. And if that is inconclusive or it comes out to be negative, then the next best option is, instead of sending just the proband, the higher pickup rate would be a trio clinical exome or a trio whole exome, in which the parents as the proband is tested together. And here we can easily confirm or rule out a de novo variant, rather than again that once we do it in the proband, we get something and then we do it in the parents. It is always better to send a trio exome for this. And again, based on the phenotype, if you are suspecting a metabolic disorder, that also can be screened. But if you do a NGS, then those metabolic disorders are obviously covered in that. So we can rule those metabolic disorders who present with features of autism can also be screened for this. And after that, if we get something positive, only then we can tell the exact risk of recurrence. And based on that, they can plan a prenatal diagnosis if we get a likely pathogenic variant, either in the chromosomal microarray or in the NGS screening. So that would be, that would be how we would evaluate a previous child, and then we'll do a prenatal.
Yeah, Dr. Jay Prakash from Jodhpur would like to know, how would you counsel a couple with an ASD child for their next child?
I think it's the same which I covered just now, that only after you have all this testing done, then we can tell them the exact risk. Risk could be as low as 1% to as high as 50% based on the genetic diagnosis, but we have to very clearly tell them that there are limitations of these tests, and the pickup rate, not to give them very high expectations. It is like less than 50%. So you can always say, yes, in 17 to 40%, we find a genetic diagnosis, and only if we find a genetic diagnosis, we'll be able to do something for the prevention in the next child.
Dr. Archana and Dr. Gayatri from Pune and Ernakulam would like to know, what is the percentage of getting positive results with NGS, or what's the level of accuracy with NGS basically?
If this is a general question, then it would depend on the phenotype. But for autism spectrum disorder, just NGS, I don't think so. There is a very high positivity until and unless we are looking for syndromic ASD. Isolated ASD, again, because I have told that there is limitation of literature. And even if we get a variant and it is in a gene which just causes susceptibility, then putting it out in the report as something significant is very difficult, often very difficult, because susceptibility genes means the child may or may not be having autism because of that, and there may be other factors which can cause it. And susceptibility genes is found in even normal population, and so we cannot rely on that to be diagnostic. But overall, I'm not sure I can give you the exact percentage, but I would not give a very big number. The pickup rate is quite low as far as NGS for mild autism is concerned.
Dr. Tanmay from Pune would like to know, should all patients of ASD be investigated for a genetic cause, or only the ones with this morphology?
This is a little tricky question, because we cannot say that all should be investigated based on the limited data. But it would depend on, my question to the parents is always why you want a diagnosis. We need a diagnosis for basically 2 or 3 major questions, that they want a diagnosis, they want to remove that anxiety that what exactly my child is having. So if they are pursuing a diagnostic dilemma and they want a diagnosis, then yes, they should be investigated, isolated or syndromic, both of them. Secondly is whether they are planning another child, then again it becomes important that until and unless we don't have a final diagnosis, genetic diagnosis, we won't be able to give them the risk of recurrence, neither can we do a prenatal. So based on what exactly the parents' pursuit is, we can suggest the testing, but I cannot say we should be testing. It depends on what the outcome would be like.
I think Dr. Sarnalata from Bhubaneswar has asked a similar question, so we'll skip that. Dr. Meena from Vellore would like to know any early clues to autism which can be picked up from early infancy.
Yeah, this is a very good question, because initially there was a recommendation that autism cannot be stamped to or put as a diagnosis in kids less than 3 years or 2 years of age also, and below that age it becomes difficult. But now literature is coming up that the screening age for autism is recommended to be anywhere between 12 to 24 months. So that is really a very early age to diagnose autism. But they say that if you screen at that early age and you can start behavior therapy or the ABA therapy, which is for specific for autism, or stimulation therapy, then the results are much better, because it is a growing brain. And if you intervene at that early stage, the final severity would be much less. So they say that by 12 to 24 months, especially in high risk families in which they have a previous child, they are definitely alert. But there are few questions which can be asked to the parents, that what do you find unusual in your child? Every child does something unusual, but there are certain clues, like if you are giving a child, even a small child, something, and he does a repetitive action for that, whether you are giving him a toy, or whether you're giving him a cloth, or whether you're giving him anything to hold, and he just bangs it or just keeps a repeated ringing movement to it. And second question is like, does he even respond to you? So sometimes a child has to be like called 2 or 3 times before he even responds to his mother. He will not turn to her, he will not involve her with whatever he is doing. And there are certain, like, he likes to be alone most of the time. So even in very early toddler stage, if there are certain red flag signs, if the parents can notice, then they say that it can give an early intervention. Secondly, there are research groups which are working on motor response of a child as early as 3 to 4 months, they say. I don't know how important that is, but they say that when they start rolling over, these children might have a different type of approach to even roll over on their stomachs or something. But this is really in a very primitive stage, and I would not like to focus so early. But yes, 12 to 24 months is the time when they can get screened by few questions asked to the parents.
And Dr. Vijay Lakshmi from Kochi would like to know, is there a test to predict recurrence of autism in the next baby?
Yeah, so the test is, as I said, prenatal diagnosis, but we cannot and we should not test the fetus directly without testing the proband. So until and unless we have testing done for the primary index case, we cannot predict the risk of recurrence in the fetus. So next baby recurrence risk is only predicted after doing a genetic test. If all tests which is available and it is negative, then we can give an empiric risk of anywhere less than 1% to 19%.
Is the carrier testing for parents compulsory if a child is affected earlier?
Carrier testing for affected child, yes, if we have found a variant of uncertain significance, then testing of the parents sort of becomes compulsory, because we want to rule out whether it is a de novo variant or if either of the parent is carrying it, just to know the significance of that variant.
So yeah, so once again, thank you very much, Dr. Sheetal, for taking time off to talk to us about this important topic. And as you mentioned earlier, there's been a lot of interest for this particular webinar, as we've seen from the number of registrations that we've had and also the audience participation. And if you have more questions or comments, please do not hesitate to get in touch with us at the email ID and the the number given below, 1-800-103-3691, or write to us at diagnostics@medgenome.com, and we will address these questions as and when we get them. And just to remind the audience again that the recording of this webinar will be sent to them in a week or two, and then you can view it in your own time. We will be posting this up on our YouTube channel and on our website, so you can always log on to that and have a look at them over there. And so once again, thanks you for the audience for registering and taking time off to participate in this webinar, and we will be having more such webinars in the future, so look out for our mail in this regard in your inbox. So thank you once again, and have a nice day. Goodbye.